Welcome to Tapping Wisdom. I'm Sue Padernacht, and I'm delighted to welcome today Dr. Sadie Elisseou, who is a physician, a trainer, and an internationally renowned expert in the field of trauma-informed care. She is a clinical trainer and instructor at Harvard University and at Boston University, and has done her education at Yale and Brown. So did I get that right, Sadie?
Yeah.
Okay. So she brings quite a wealth of practitioner as well as scholarly experience in the area of trauma-informed care. We met last year after she was a panelist at the healthcare burnout symposium at the New York Institute of Medicine. So we've stayed in touch. We've talked a lot about the issues of clinician burnout. And I thought Sadie's leadership in getting the adoption of trauma-informed care at medical schools and in practitioner practices to be really important to share with our audience. So I'd like to welcome you, Sadie, Dr. Elisseou, to our program. And I'm wondering if you could introduce yourself to our audience.
Thank you so much, Sue. It's a joy to speak with you always, and I appreciate the honor of the invitation to speak on this podcast. As you mentioned, I am a physician. I am specifically a primary care physician, and after I finished my training, I immediately joined the VA healthcare system. So I am a PCP for U.S. military vets. Currently, I work in the Boston VA healthcare system, and I teach at Harvard as well as BU. And my primary interest and area of expertise is this field called trauma-informed care, which may or may not be new to your listeners. So that is what I really enjoy spending most of my time and research and teaching doing.
Well, why don't we just get right into it? There might be some people who know what this is and other people who think they know what this is, but may have a different definition. So why don't we start with just an explanation of what trauma-informed care is?
Sure. This was an entirely new subject for me just several years ago, so I have learned a lot. And it is a field that is rapidly growing. So I think that now is a good time to be learning about what this is if you don't already have familiarity. Forgive my voice, I'm still have laryngitis from COVID.
Oh God.
Yeah.
So this is, December of 2022. So it's
Yes.
all over. Okay. So I hope you feel okay.
So trauma-informed care is an organizational framework for providing quality clinical care to people who have survived various forms of trauma. And that could be physical trauma, psychological, sexual, or even transgenerational historical trauma. And it was primarily born in the social services, behavioral health sphere, but in recent years has become exceedingly popular throughout all subspecialties of medicine and even surgery. We're seeing it crop up in both undergraduate and graduate medical education in the United States and overseas as well. There's a lot of advocacy and policy work going on for trauma-informed services, and we're applying trauma-informed principles now outside of healthcare and outside of patient care. So the idea is that there are 6 main principles of trauma-informed care. And I think if we're going to have a rich discussion about what this is, these 6 principles may be worth sharing now so that people kind of understand.
Yes, please, go ahead.
Yeah. So the first principle is safety. That means physical, psychological, and emotional safety. Before we can do any work with our patients, before we can work effectively in an organization, the environment needs to be deemed safe. Number 2 is trustworthiness and transparency. So all of our operations are conducted transparently with the goal of building and maintaining trust. The third key principle of trauma-informed care is peer support. So we connect with one another in pain and in healing to both gain and inspire hope. And fourth is collaboration and mutuality. Importantly, there's a leveling of power differences and a meaningful sharing of power in relationships, whether it's patient provider or employee supervisor, whatever it is. Five is empowerment, voice, and choice. So we build on people's strengths and support their autonomy. Their voice matters. And six is attending to cultural, historical, and gender differences. So we recognize that trauma has been passed down in certain populations through history. And so we aim to recognize that and address it. I must say, I should have noted previously, these six principles come from SAMSA. SAMSA is the Substance Abuse Mental Health Services Administration, and they're really pioneers and leaders in identifying a framework and understanding of what trauma-informed care is and how to operationalize it.
Okay, there's a lot here. Why don't I take a step back and ask how you stumbled upon this and how you went from learning about it for the first time to becoming an expert, right, in implementing this at the VA, teaching this at Harvard, really trying to get this kind of like an ecosystem of care. Right. So, because it's not just one thing, it's at the organizational as well as practitioner level, adopted, throughout, not just the VA, but other medical systems too.
Yes, of course. It was very coincidental, in my view, because I happened to pick a job at the VA when I finished chief year, and I could have gotten a job anywhere else. The VA happens to be a place where the patient population has higher rates of childhood adversity and childhood trauma, exposure to combat, and a host of other lifetime exposures to trauma. And many of our patients have a condition called PTSD. Not everybody with trauma develops PTSD, but some do. And so my patients happened to be more sensitive to what I was doing on the physical exam. As a doctor, we touch people, right? We listen to their heart, we press on their knee, we look inside their ear, inside their throat to figure out a diagnosis, which will inform treatment. Patients were a little jumpy during the exam, perhaps a little tense and on edge, perhaps not wanting me to touch certain areas or proceed with the exam. Were hesitant. And I remember specifically a patient really jumped when I swung my stethoscope off my neck to listen to them.
Yeah.
So all of these experiences were kind of hurtful in the moment, like, oof, man, I did not intend to cause harm, right?
Sure.
Because the oath that we took was first do no harm. So what are we doing here? Something needs to change. So I started adjusting how I spoke and where I stood and how I approached people in the room, simply in an effort to make them more comfortable. And I started teaching those strategies through a lens of compassion and curiosity, humility to medical students. And the students in the small group that I was assigned to at Brown, where I was teaching, just happened to have done previous work in trauma-informed care. And they asked me to teach them more about my trauma-informed approach. When they said that, I really had no idea what they had just said. It zoomed by me. I was like, trauma, what are you talking about? And they had to explain what it was. And as soon as they explained it, I was floored. Like, why hasn't anyone told me this before? How did I go through med school and residency and all this? I'm taking care of trauma survivors. Nobody thought that this was going to be important for us to know. So I learned more about it. I read everything that I could about trauma-informed care, whatever was published online. And I decided to develop a formal framework for what I called a trauma-informed physical exam. To approach people in a sensitive manner before, during, and after that exam. And I had the the blessing, the fortune of being the course leader for the doctoring course at Brown at the time. So I decided, hey, let's make this standard curriculum for everybody. We implemented it, we studied it, we published it, myself and two other medical students. We won an award for it, and it's being taught now at healthcare institutions and medical schools across the United States. And I don't think that would have happened had I not been working with veterans. I don't think it would have happened had I not been working with medical students who knew about this. And I don't think it would have happened had our society not been ready for this culturally. Importantly, wherever there's a new curriculum happening on trauma-informed care in a medical school, it's not usually coming from the faculty or the deans that are asking us to do this.
From the medical school, you mean?
Students, of course. It's this generation of people that has this on their minds and on their hearts. It's, you know, social justice and equity is just a charge that is now infused in medical education. We're not just being called to medicine to treat physical illness. It's psychological illness, and it's social illness and injustice.
Thank you for sharing that. Can you just share just real quickly where you're published, so our audience can search some of your work?
Sure, of course. I am published. I have a couple articles on MedEd Portal, and MedEd Portal is a peer-reviewed venue for publishing MedEd curricula. There's that, and then there's also an article on trauma-informed telehealth, which I published with VA colleagues in the midst of the pandemic, and that's located in Federal Practitioner.
I got it. So since you started doing this work in the years that you've been doing this, seeing this in medical schools and doing this at the VA, and seeing, you know, people graduate from medical schools with this nomenclature and with these processes and with this kindness. That's the word that kind of pops into my mind is, you know, kind of approaching, you know, patients with kindness and not assumptions about what they're going through. What is kind of your vision, kind of long term, right? Where are we now in this since you started, and where would you like to see this go? You know, whether it's internationally, in the United States, locally, you know, kind of take your pick.
Yes, lovely question. Always good to think big and think future, right? And that's what a leader does too. So my vision is for trauma-informed care to become the standard of care across medicine and surgery, across healthcare internationally. It needs to be embedded in the way we do business, something that just is. And this needs to be part of the content of what we teach in healthcare professions education, as well as the context in which learners learn.
I'm sorry, go ahead.
No, that's it.
Yeah. So with regard to that, you talked about this being an organizational framework. So because we've talked many times, and it's almost universally understood at this point that burnout, you know, whether it's in the healthcare industry or the education industry, et cetera, is very much systemic. It's not, you know, it's not just at the individual level. Of course, it's both and, but it really starts at the systemic level when we're looking at core issues, causes. So can tell us a little bit about the organizational framework that you referenced earlier?
Yeah, I think what comes to mind for me is recognizing where we've been and where we're going with our concept of trauma, because traditionally when we heard the word trauma, it was a physical wound or injury, right? Like a gunshot wound or motor vehicle collision, that's trauma. Now we've kind of grown to expand our definition of trauma. SAMSA's definition is that this is really any event that is experienced as harmful or threatening and has lasting adverse effects on our function and well-being. So now we have a broader definition, but it's still kind of something that our patients suffer from. Trauma
Yeah,
and
it's subjective, right? It's experiential.
yeah,
Yeah.
but not it's for them, it's not us meaning healthcare professionals. Where I'd like us to kind of move, and from a trauma-informed lens, we can see this. Trauma affects all human lives. This is a kind of very natural, expected part of our mortal existence. And
Mm.
so it's not something that only patients face. It's something that healthcare trainees and staff and employees and people in the C-suite are also facing. And so we need to implement trauma-informed approaches on the individual, interpersonal, institutional, and systemic levels for us to move towards healing, recognizing that burnout is a national crisis.
Yes, absolutely. And let's talk about that. Let's transition to talking about how doing trauma-informed care is both empowering of physicians because they're more effective with their patients, and it's also helpful for physicians themselves who are themselves dealing with burnouts, right? So it's a healer,
Yeah.
heal thyself, right?
Yes, exactly.
Yeah.
Burnout is a really important and real term that we can describe, that we can use to describe what health professionals are experiencing. But in my view, right, as a subject matter expert, trauma needs to be on the table. We need to start using that word more to describe this burnout phenomenon, because it is likely often much more complex than just systems barriers and cognitive load and slow computers and overflowing clinics and reduced staff. All of that is real and important. It's just not the full story,
Mm.
especially as COVID has brought to light all of the other forms of suffering that clinicians may face, including compassion fatigue and moral injury, moral suffering, et cetera, et cetera.
So,
So
and I'm wondering if that relates back to one of your principles, being peer support.
Huge, huge, which is so hard now in this era of working remotely and doing a lot more telehealth and telework, is it can lend itself to more isolation. It has real perks, and I'm here in my home office and I'm loving working from home today. But we do need to be mindful that we have lost a little bit of that peer support over time. And from a trauma-informed perspective, healing happens through people. Healing happens through relationships, specifically safe, collaborative, trustworthy, nurturing relationships. And we often find that at work. We find that with our colleagues.
Yeah, yeah, that's true. And so we've got some types of medical specialties like primary care, as an example, where doing some of the work remotely is possible. Um, Now let's talk about the anesthesiologists, right? The surgeons, the ones who don't have that as an option, who many of whom are in organizations where, you know, there are staffing shortages and they're working more hours. There's a lot more back to back, and there isn't, you know, so I can almost hear them saying, I don't have time for peer support because I'm already putting in, you know, 14-hour, 15-hour days, and I'm just back to back. So um so that's going to be the pushback. How might an organizational framework for trauma-informed care support those kinds of practitioners, those kinds of clinicians?
Yeah, what comes to mind for me is that this also involves a cultural shift. What needs to transform in an organization is for us to recognize that we are all human, we all have pain, we all have growth and healing, and we need to lean on and help and support one another. So if I'm going into the OR as an OR tech, and I see that the surgeon scrubbing in looks really forlorn, exhausted, ragged, I can say, hey, you look a little down today. Is there something I can do to help or make things easier? You know, we need to have a culture that supports that kind of a compassionate inquiry with one another, and just, hey, how can I help share the load or perk things up today?
I'm glad you talked about that in terms of culture because, answering, affirmatively to that question, yes, I am, I am tired. Thank you, is historically counterculture,
It
right? To the
really is.
physician.
Oh my gosh, counterculture to life in general. I was actually so shocked
Mhm.
this week watching TV, and there was an ad for a company. I guess I won't say the name of the company, but it's very
Sure.
big. And it showed a mother in the post delivery period with her
Oh,
newborn, breastfeeding and looking completely wrecked.
yeah,
And
yeah,
then she gets a package delivery at the door that says, hey, just want you to know you're doing great. And like the relief on that mother's face. And so a few years ago, we would not be seeing this in a TV commercial.
yeah,
We would be seeing the glorified,
yeah,
beautiful baby, perky, glowing mother.
yeah,
And so we're in an exciting time in history
yeah.
where we're recognizing the realness of mental health
Hmm.
and the
Hmm.
whole spectrum of challenges that we face because um, mental health happens in the brain. It happens to be a very real, very important organ. It's not something we're making up. There are actual chemicals that we can measure that change when we're feeling calm or when we're feeling a little hyper aroused and activated, whether it's from a current stimulus that's painful or triggering a memory from the past from a painful experience. So it really is an exciting time of growth, I think, for our society. And we
I'm
can
so
have
glad you brought up measuring because that was going to lead to my next question. So the other voice that I can hear is the voice of the hospital system or medical practice, CEO, CFO, who are saying, wow, this is really a heavy lift. You're asking us to make some, pretty substantial changes. How do we know this is going to matter? What's the return on investment, the ROI?
yes,
Why should we do this heavy lift?
yes, Sue. So
Mhm.
researchers in the field of trauma-informed care are working hard to get those detailed cost effectiveness data that everybody has been looking for now for years. We don't have enough information to be really juicy and appealing yet
Mm,
to those individuals. What we have so far is some really appealing positive outcomes in healthcare. For example, training providers in trauma informed care increases patients' ratings of their providers in the realms of communication and comprehensiveness. It also increases patient satisfaction with their care, which is really a big measure for hospitals in general. And it increases employee psychological safety scores. And psych safety is a really big buzzword now in
mhm,
companies across the board.
mhm.
The
Right.
other thing is sometimes we should just do good stuff. It's good to do.
Yeah, right.
Sometimes we don't really need money data to be kind.
Yeah, 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 yeah. And I appreciate you talking about, how work, it's still early days,
Yes.
right? So what early days means is that we have early adopters,
Yes.
right? And the great thing about being in part of the change, being, from a change management curve, right? We have the change, innovators, the people who like you who have created, your framework. And then we have the early adopters who are accepting it, but may also be informing how it can be shaped and adapted in different environments, like taking the primary care versus the surgeon, kind of
Good.
situations. This is from
Good.
their employee psychological safety, and from a patient satisfaction standpoint, it needs to kind of be adapted. So there's probably, so it's probably iterative and there's some feedback going on until it gets to the wait and seers, right? In the change, in the change management curve, right? So it's not that they're change resistant, but they're kind of waiting and seeing, the pilots, right? The early days before it comes to theirs, because they're a little bit more risk averse.
Yes, exactly. And
Mhm.
you're right that trauma-informed principles can be adopted and applied to any number of things. If you just do a simple Google search, you'll find trauma-informed interior design. You will find trauma-informed yoga. You'll find all kinds of um, industries where those 6 principles from SAMSA that I had mentioned earlier can totally be influencing daily operations and procedures, practices, etc.
Ah, I understand. So this isn't just in the healthcare industry anymore, and I say healthcare to include physical and mental health. So
That's
it's the
right.
psychological sciences, social sciences as well. But you're saying it also has to do with physical space that people are in. And so I imagine that when we see hospitals investing in, more pleasant colors and light in their
Right.
spaces and greenery in their spaces, that might be an example of
That's
what we're starting
exactly
to
right,
see.
because there are neurobiologic mechanisms that can describe why individuals may feel more at ease in open spaces that have natural landscape or greenery visible, and why people may feel worse in like a bright orange tight room
Yeah.
that's cluttered. And
Exactly.
informed care is actually really huge now in public education as well as legal services.
Oh,
All
interesting.
kinds of articles on trauma informed lawyering. And there was a Harvard Business Review article in mid 2022 that was titled, something like "We Need Trauma Informed Workplaces." So this is a
Yeah.
really quickly growing movement.
That's wonderful to hear. And so my last kind of big question before we pull this together is let's talk a bit about healthcare, trauma informed care access, right, on the healthcare side, right? So as we know, there are many communities, nationally, internationally, that might not be in the early adopters. They may be, but the chances are that they may not be on the receiving end yet of trauma informed care. So for the people listening to this and they're saying, I do my work in this community, what can I do, to start to get at least the conversations going and maybe get the process going, for us, so more people have access.
Yeah. What comes to mind for me is something else from SAMSA, which is the 4 R's of any trauma informed organization or program or approach. So the 4 R's are the following. Number one, we need to realize the widespread impact of trauma. One national study showed that 89% of the US population will experience at least one traumatic event in their lifetime. My God, that's very
89%. Wow.
mm-hmm.
With the
And then,
11% that
right,
get out, they get out
right,
free,
absolutely.
right?
Yeah.
Yeah.
I know from
Wow.
many studies of adverse childhood experiences, also known as ACEs, that at least half of us have experienced at least one ACE in the realms of neglect, abuse, or household dysfunction. So realize that this is widespread. If you don't think it's in your hospital, if you don't think it's in your company organization, you need to open your eyes to the facts. Number two is to recognize the signs and symptoms of trauma. So this doesn't have to be florid PTSD symptoms of nightmares and flashbacks and sweating and being on edge and all that.
Sure.
In the workplace, this can be as simple as irritability, missed deadlines, difficulty concentrating, reduced energy, difficulty relating to peers, absenteeism, et cetera, et cetera, et cetera. In and number three is respond. So the third R is to respond by putting trauma informed measures into practice, both now and in the long term. And four, importantly, is to resist re-traumatization. This is particularly important for clinicians like myself because everything that I was doing for my patients in the physical exam early on, I did a lot of stuff that was maybe re-traumatizing. When you think about the physical exam, people are undressed or underdressed under a flimsy gown. They're being touched by a stranger, asked personal questions. They're wondering, what am I going to discover about my health that's horrible? So it's a vulnerable, uncomfortable situation. There are many very routine examples in an average workday of ways that we can become re-traumatized. I remember working with a healthcare leader who was having a hard time functioning at work because her supervisor reminded her of her ex-husband who was an abuser. And so you wouldn't necessarily know that
Yeah.
unless you knew that, right? So we cannot make assumptions about what's really going on with people. We just need to be in an environment where we're a little bit more understanding. Big phrase, the catchphrase of trauma-informed care is moving from the traditional and accusatory, what's wrong with you? What is wrong with that woman? To the more compassionate inquiry, what happened to you? What has happened to her that has affected her in this way? Because it's hardly ever true that people are trying to be a bad person, right? We're all trying to do the best we can in any given moment, in any given circumstance.
Yes. So it's basic. So we're talking about giving people grace.
Yes.
And we're also talking about part of the resist re-traumatization. That seems really consistent with, the Hippocratic Oath of doing no harm.
Yes.
Right. And so taking, all of the humanity of the person who is in front of us, whether they're a patient or a client or a student, and also doing that for ourselves, and in the spirit of peer support, with our colleagues as well.
That was well said, Sue. I entirely agree.
Well, you're a good teacher. So in the spirit of that, what have I not asked that would be helpful for people to know?
I'd like to share perhaps one tool that I find extremely powerful and influential in expressing empathy successfully to people who are going through something really distressing, because I feel that it's my superpower as a physician, far more than my prescription pad or anything else I learned in school. I feel like relating well to people and communicating care and offering some healing in the moment, that's what's really transformative. So this is an acronym. It's not something I made up. It's something someone else developed. You can find it online. It's called the Nurse Acronym, N-U-R-S-E. And N stands for name, U is understand, R is respect, S is support, and E is explore. If you have, I'm going to share with you what I can say in a string of sentences to someone, and then I pause. And if I have time, I can explore it further. So, for example, if someone is looking very, very upset, very frustrated, you can say, sounds like this has been a really frustrating time. I can understand how you'd be feeling that way. It sounds like you're just doing the best you can. And my only role is to support you. And then you pause. I remember the first time I used that tool, it was with a patient who was so overwhelmed with pain and aggravation. He was honestly vibrating in the office.
Oh my gosh, yeah.
I was covering for a doctor. I had no idea who this person is, but he came in this way. And I just sat in silence, kind of offering space for whatever he had going on. And when I said that, he paused, his shoulders dropped, and he started sobbing. And he said, nobody has ever spoken to me like that. Will you be my doctor? And that was the start of a beautiful therapeutic relationship. So I share that because it can be a tool to express something that is already innate, that is already inherent and in you, but sometimes these skills for communicating in a trauma-informed way are learned.
Yeah, indeed. And we do know that because we're social beings. We are neurologically wired to have compassion and empathy, right? We are social beings, but it's easy to forget that when, we're only being reimbursed for, 10 minutes per patient, and we're thinking, if I use the nurse acronym, it's going to extend the amount of time. But what I'm hearing you say is you almost need to slow down in order to speed up, because people aren't feeling judged, they'll actually opt in. And I think, Sadie, of all of the misinformation and disinformation, in that has been out there, especially since COVID, right? And all of the disheartening, interactions that clinicians, certain nurses as well as physicians, right, and all of the healthcare providers, not just doctors, have experienced by being disrespected and not trusted and so forth. And so, one of the things that that I found in my work is you can't change what the patient is exposed to, but we can change how we interact with them, when they're doing that. So I can't help but wonder if this as people in the clinical world are adopting this, are using it to help, kind of soften the heels dug in that some patients bring to their resistance and disrespect, toward their clinicians.
I think that these are just essential people skills, and we need people skills in any business ever. I don't know if there's a business where you don't need to know how to interact with.
Yeah, absolutely. So before we close, I'm wondering if you could share with our audience like 3 big takeaways that you would love for them to take from our discussion today.
Well, I know that you are an expert in leadership and that you coach individuals on how to be more effective leaders. And perhaps I can share a couple, 3, I guess, things that have helped me in my leadership in the realm of trauma-informed care to kind of move this forward and allow trauma-informed care to have a greater influence. I think for me, the first is warmth. I try in all of my interactions with people to communicate warmth in my verbal and nonverbal communication to make them feel heard and valued, and to make people feel and believe that they matter. The second is curiosity, kind of an unending spirit of learning. In medicine, this comes very naturally because we are lifelong learners. That is something that we kind of take on as our identity. And so I am constantly learning from patients and from more things in the literature, from colleagues, from people, from experiences. So I'm, yes, an expert in this field and still learning. And the third, I think, is persistence, because I had it inside me that I knew that we could improve things for patients. I knew that we could improve things for students in medical education. I knew we can improve things for employees struggling with burnout. And if you have this inside, I just don't think you should rest until what that is understood, it's communicated, it's talked about, and it's implemented for change.
Thank you. Those are 3 great takeaways. And in the spirit of persistence and continuous improvement, where are just a couple of credible sources where people can go to start to learn more about trauma-informed care? And I'm sure from there, then they can branch out. But where are some good starting points?
Good starting points. I would say that SAMSA is definitely a great thing, entity to look up to learn more about the original conception of trauma-informed care, all of the principles, what they mean, how to, what are the domains of implementing trauma-informed care in any organization. Another one is ACEs Aware. ACEs Aware is an entity that was led by the former Surgeon General of California, Nadine Burke-Harris. There's now a big team around that. And there are many trainings related to ACEs. Again, that's adverse childhood experiences, and an understanding of neurobiology of trauma, healing from trauma, etc. Another one is PACES Connection, stands for Positive and Adverse Childhood Experiences, and it's a forum for fellowship and advocacy and training related to trauma.
Wonderful. Thank you for sharing that.
Sure.
And how could people get in touch with you if they're interested in this from an organizational standpoint, for for doing some corporate training around this? How can people reach you?
Sure. I think the two easiest ways are on LinkedIn. You can search for Sadie Elisseou, and the second way is my website. It's sadie-elisseou.com. I would be happy to hear from you to continue this conversation. And I'm just excited to get this message out more in the world.
And I'm excited to support you in that.
Yes.
Thank you so much for joining me and joining us today. And in the meantime, this has been Tapping Wisdom. I'm Sue Padernacht, and thank you for joining us.